Hello, everyone, and welcome back. I am so thrilled to be here once again, and I have with me Megrette Fletcher. Megrette is a registered dietitian, diabetes care and education specialist, public speaker, and author. She is a mindful eating leader and co-founder of the Center for Mindful Eating and Inclusive Diabetes Care.com, a continuing education company for professionals working to improve inclusion and health equity in diabetes care. Her focus on decreasing stigma fuels her passion for weight-inclusive diabetes care, treatment, and prevention. Welcome, Megrette.
Thank you so much for having me. So, um, this program, we get to be together for, it looks like about, we're going to be talking until about 12:30. And in that time, just so you guys all know, we have about 83 slides we're going to be moving through. And there will be time at the end of the section for question and answer. Um, so that's really great. Um, my disclosures are on the top of the screen, so you can see those. And let's go through those learning objectives as well. So the first learning objective, what is weight-inclusive diabetes care? I think we all have that question. And how does weight-inclusive care decrease or increase clinical engagement? So how does that improve outcomes? How do diabetes and weight stigma, how do they intersect? How is weight stigma measured? And how is stigma measured in chronic conditions? And the last question is, does an inclusive approach facilitate approach to diabetes? Does that facilitate the sense of belonging? So we've got some lofty goals and we're going to jump in. I'm going to try not to rush, though it is a wish sometimes that we do. But let's talk about Sarah. So we're going to meet Sarah. She's been newly diagnosed with type 2 diabetes, and T2D stands for type 2 diabetes, just a shorthand. And yeah, here are some things Sarah might be juggling. Her feelings, treatment, and lifestyle changes, how this might impact her family or social life, views around healthy aging, medical care, current and future treatments, maybe costs. She might also be juggling her past health experience. Does she trust receiving medical care? Does she feel seen and heard when she's engaging in medical care? Is she being asked to do things that are beyond her ability? Is she experiencing any form of stigma? So in this first section, we're going to really talk about what weight-inclusive diabetes care is. And hopefully at the end of this, you're going to have a pretty clear sense of what that is and kind of going forward from that. So, when we think about her options, what are Sarah's options? A lot of times the focus is on losing weight. So her options might be to restrict her intake, for example, sugar. Might be removing or limiting specific macronutrients. And the macronutrients are carbohydrates, fats, protein, and alcohol. So specifically here, maybe carbohydrates. Exercise, we all hear that 10,000 steps or 150 minutes of exercise per week. Our options may be to record her dietary intake, maybe through a food log, or to track her dietary intake, maybe through food or weight loss apps. She might want to explore other options, including weight loss medication or surgery. And this makes sense if you believe that weight is under the individual control. An imbalance in calorie intake and energy uses causes weight gain. Health status can be predicted by weight. Excessive body weight causes disease and early death. Successful long-term weight loss methods involve modifying eating and exercise patterns, and losing weight will result in better health. So, what I just described to you is the foundation of weight-centric medical care. And it's really important that we take some time to understand what are the consequences of weight-centric approach to diabetes. And I think it's really helpful. There's research out there, and including an excellent 2022 review article that explains the harm of a weight-centric approach has in healthcare and on clients. And yeah, I purchased this and printed it out, and I have it by my desk because it's such a great um, resource to have when people are curious, or when you're curious and you want to dig in a little bit deeper into, what are the consequences? So the key points of this review are that promoting weight loss worsens societal weight stigma. It often leads to weight cycling and increased risk of disordered eating and eating disorders, all of which can negatively impact health and well-being. Dieting and weight cycling also leads to negative psychological consequences. Instead of focusing in on weight and weight loss, healthcare and public health recommendations should address the environmental and social determinants of health. Now, it's easy to get lost in this talk, so if you can just put a little asterisk next to social determinants of health, we're going to talk more about that later on in this program. But please note, when we talk about diabetes, we really do have to include that in. So I think what's really interesting is that, dieting, it isn't a cure. And this is one of the things that a lot of times we hear, like, oh, weight loss can cure diabetes. But the American Diabetes Association states research shows that yo-yo dieting may increase insulin resistance, a condition that occurs when your body can't efficiently use insulin that it naturally produces. Insulin resistance can lead to type 2 diabetes. And for those whom already have diabetes, it can make the condition worse and far more difficult. Now, if we keep going, weight stigma increases the risk of diabetes. Recent article, same one, published in 2022 in the Journal of Diabetes. Persistent weight reduction is often hard to maintain, with less than 6% of subjects able to sustain weight loss during a 15-year period of time. Current efforts suggest that repeated weight loss and subsequent regain, a phenomenon known as weight cycling or yo-yo dieting, exacerbates the risk of type 2 diabetes and cardiovascular disease. So if we really want to dig deeper into weight cycling, we have a 2022 article. This is a review study, and it states pretty clearly weight loss is rarely maintained. Weight cycling is associated with increased risk of mortality in patients with type 2 diabetes, and mortality is death. Meta-analysis shows that weight loss is generally not associated with the reduction in mortality risk for type 2 diabetes. And whereas weight cycling is associated with increase in all-cause and cardiovascular disease mortality. This may be attributed in part to the increased variability of cardiovascular risk factors that are often accompanying weight cycling, which studies show is consistently associated with adverse cardiovascular disease outcomes in patients with type 2 diabetes. This particular study is quite powerful. So I think this is a review. Again, he's looking at all the different studies. Inconsistent association between weight loss and mortality risks in type 2 diabetes. Consistent findings that elevated mortality risks associated with weight cycling present a conundrum for weight loss focused type 2 diabetes prevention and treatment. This is further complicated by the finding that among patients with type 2 diabetes, mortality risk is lowest with a BMI body index between 25 and 35. And he goes on to describe the obesity paradox, which has consistently been demonstrated in 7 meta-analyses, that the lower mortality risk for individuals with type 2 diabetes in this BMI range may not at all be paradoxical. It may, in fact, be not unhealthy to be in that BMI range. So again, he's starting around saying our thought process around weight is flawed. Again, physical activity, cardiorespiratory fitness, muscular fitness are all associated with a reduced risk of type 2 diabetes. It lowers cardiovascular risk and all-cause mortality in people with type 2 diabetes. Reducing sedentary behavior independent of physical activity status is also strongly associated with the decreased risk for type 2 diabetes. Sedentary behavior, joyful movement, just moving helps us. Improvement in cardiometabolic risk factors with exercise training are comparable to those observed with weight loss interventions and are largely independent of weight loss, i.e., exercise does not make you thin. It's not what causes weight loss. To minimize the risk associated with weight cycling, it may be prudent to adopt a weight neutral approach for prevention and treatment for individuals with obesity and type 2 diabetes by focusing on increasing physical uh, activity and improving respiratory fitness and muscular fitness without a specific weight goal. So one of the things we can do is taking care of your body isn't the same thing as pursuing weight loss, and that we really want to focus in on behaviors that promote health. That's talking about eating a balanced diet versus a restrictive diet, talking about eating paired macronutrients, that carbohydrates and protein together. And for those that are unaware, when we eat carbohydrates with protein, protein does stimulate a little bit of insulin release. And so that's why we recommend that. Also blunts blood sugar rise, which is really helpful. Engaging in movement. It doesn't have to be like sweaty movement. It's just movement. Noticing and attempting to eat and stop eating when hunger and fullness are both pleasant. When we wait to eat and our hunger becomes unpleasant, that's actually not helpful. When we eat past fullness and fullness becomes unpleasant, again, not helpful, but diet culture, that's what diet culture is encouraging us to do. Hunger is bad, fullness is bad, everything's bad. Become aware of non-hunger eating and explore options to include continuous glucose monitor or adding diabetes medication. And for those people with diabetes that are listening to this, really want to just give a shout out to technology. Diabetes technology is really mind-boggling. It's so amazing. And we know that a continuous glucose monitor is effective. It's as effective, can lower A1Cs up to 1 point. So instead of having an 8, you could have a 7. CGMS is really becoming industry standard. It is so impactful when we talk about awareness of what impacts blood sugars. It's really amazing. But a lot of people aren't being offered CGMS. They're being offered weight loss surgery. And you got to scratch your head why. So the summary, a weight inclusive approach acknowledges that weight loss is not helpful for every person with diabetes, that there are risks associated with dieting. It is not risk-free. Dieting can increase the development of type 2 diabetes, worsen heart disease, and engaging in a non-weight focused behavior change can support blood glucose management. So I believe, if I'm lucky, I think I can see any questions. But if people have questions, now would be a great time to maybe put them in the chat and let us know, because it is a very dense program and I do have these breaks in here so we can kind of start understanding kind of what people are thinking or feeling. And yeah, so let me just look at that chat. Yeah. All the citations are at the end of this, so they are all cited at the end. Back to meta-analysis. That's a lot of studies. 7 meta-analysis. Thank you so much, Marissa. I agree. It's a lot of studies. Yeah, so again, yes, CGMS isn't for everybody, but again, for those people it works for, it's really, really powerful. Um, and again, when we are looking at, technology, we do want to be able to offer technology to everybody and not associate that, fat bodies don't benefit from technology. Of course they do. And so we really want to recognize that my experience in the diabetes community is that uh, people are not being offered CGMS very, very often. Um, so Medicare is changing their guidelines around CGMS. So hopefully, fingers crossed that that will happen soon. Um, yeah. Um, Yeah, I do think that when we start thinking about the social determinants of health, we are swimming in the waters of diet culture, and I think that that is, really, really hard. Um, yeah, and again, there's a couple of comments talking about how fat bodies CGMS don't work, and I support, that. Um, but I work with people with fat bodies, and they work great for them. So I think it's an individual choice. Um, Do you know if dieting and restrictive weight loss efforts can increase blood sugars? So I think, again, what we talked about was the yo-yoing. I think a lot of times when people are on a diet, they're restricting, and then maybe they have medications set up for that. And then when they go off the diet, they're not restricting, and then the medications may not be adequate. And so we're going to kind of get a little bit more into that. Beautiful. Yeah. All right. And I do think that monitoring, again, kind of going back to the technology, pricking fingers is, again, it can work for some people, but a lot of people really do appreciate having that CGMS. Um, yeah. So there we go. So I'm going to pause the questions and we're going to keep going. So really increasing clinical engagement as part of diabetes prevention. Um, so, preventing diabetes and associated complications. So when we talk about prevention, I think this is one of the things that gets a little bit confused. And one of the things is prevention includes programs that reduce the total number of people with prediabetes or diabetes. So that's one aspect of prevention efforts. Prevention also includes, delaying the diagnosis of diabetes. So that's another aspect. Prevention efforts include reducing complications associated with diabetes. And these can include, kidney, eye, and heart, and also reducing the loss of hearing, the loss of feeling in our sensations or vision. And increasing clinical engagement is part of all diabetes prevention. So when we think prevention, just try to lay that out a little bit bigger so we can kind of see that. So I want to go through, hopefully I'm not talking too long here, um, 4 studies that are going to kind of go through this in a little bit more detail. Yeah, okay. So the first study it's a 2020 article by Poole, and this study is looking at 122 patients with type 2 diabetes, and it's really looking at internalized stigma of those. And really, both internalized stigma and diabetes self-stigma were both significantly associated with higher diabetes-specific distress. And adults who express self-stigma for their diabetes reported less diabetes self-management, lower self-efficacy. They also reported feeling judged by their weight, and by doctors also exhibited greater, they also exhibited greater diabetes-specific distress. And there were lower quality interactions between healthcare professionals reported by adults who expressed diabetes self-stigma and those who experienced weight stigma from the doctor. So kind of the conclusion from the study is self-stigma from diabetes or body weight, as well as experiencing judgment about weight from doctors may have negative implications for diabetes-specific behaviors and perceived quality of care. And so again, harken back to Sarah and some of the things she's thinking about. Does she trust diabetes? Does she trust her medical care? And again, when we think about diabetes, a person with diabetes doesn't feel like they belong. This may be because they receive different treatment than somebody without diabetes. Diabetes is very number focused. Blood sugar, A1C, time in range, weight, they all contribute to this common experience. And many people with diabetes don't have a sense of ease, which is worsened by adding restrictive eating, exercise, food tracking. This all adds to the burden of a chronic disease. So we're going to look at our next study. This is 2023 by Bennett and Poole. Again, this study is looking at attitudes of individuals with type 2 diabetes among physicians who treat them. And so again, this is pretty hard data that we're looking at. So it's specifically looking at internal medicine and endocrinologists. It's looking at the attitudes that they have towards patients, um, where contributions are of controllability and blame of individuals with type 2 diabetes and obesity. And again, I use the word obesity because it's directly from the research. It's not a word I choose. And a third of them reported that they were repulsed by people with type 2 diabetes, that 39% said that they were lazy, 44% lacked motivation, 44% non-compliant. People witness professionals in their field making negative comments. So this is other providers listening to other providers. And physicians who endorse worse levels of bias towards patients with diabetes. But the differences were small. And really, it highlights the idea that we need to really work in the medical community to address stigma. And research assessing the effects of type 2 diabetes stigma and the quality of patient care and health outcomes is really needed. So 2023, it's pretty close. Personally, when I read this story, or read this research, I was nauseated by it. So, and this is kind of continuing the client is a number on the scale. If a person with, diabetes doesn't feel seen when they say, dieting hasn't worked for me, or I don't want to exercise, or I'm not willing to go on a diet because I've had an eating disorder, a person often feels judged when they advocate for themselves. I can't start a diet now. For many clients, especially those that have been marginalized, this approach doesn't feel, client-centered when we're interpreting what they're saying as they're being non-compliant. It isn't patient-centered. We really have to see our clients. We have to kind of imagine where they're coming from. Again, harken back to Sarah. So at multiple fronts, again, we're looking at diabetes. 2020 article, again, what they're looking at is about 100 and, 1,200 patients with type 2 diabetes. It's a questionnaire. And really what they're saying is that 50% have experienced weight stigma. 40 to 60% of those experiences happened in the context of healthcare. Participants reported frequent diabetes-related stigma, including blame, judgment, self-stigma, and differential treatment. And they identified that white women had some greater risk. So again, what we're hearing is the conclusion is that people with type 2 diabetes report higher rates of weight stigma than the general population, experience higher rates of diabetes-related stigma. Many internalized these forms of stigma. Um, yeah, really, we have to spend more efforts really trying to reduce this because it's creating a barrier to care. So another research article, again, this is a questionnaire, 2022. Um, does stigma, weight stigma, diabetes stigma, does it change behaviors? So it is associated with an increased frequency of binge eating, eating to cope or deal with negative feelings. And internalized weight stigma also significantly is associated with lower levels of physical activity and worse self-rated health. So again, the conclusion here is saying that both weight stigma and diabetes stigma need to be addressed for people with type 2 diabetes because when they experience this weight stigma, it leads to maladaptive eating behaviors. It leads to disengagement in medical care. And so when we start really thinking about that, at one hand, this belief that weight and weight loss is without harm, now we're really seeing clear evidence that say that's not accurate. It's not accurate. So I think that's really important to understand that when people say, well, there's no harm in suggesting weight loss, now you're turning around saying, no, no, there is harm. It's clear. There's clearly harm. Oh, well, people don't, it doesn't hurt anyone when I say, why don't you go on a diet? It does hurt people. And so we're really seeing that. And so again, when we kind of think about it from the client's perspective, what's their impact? What are they thinking? You know, there's distrust. Why don't they think I'm not currently trying? Like, why do you believe I'm not trying? That doesn't make any sense. The clinical inertia, we really talk about that. Delaying care as part of a provider. Would you delay treatment for everybody? Yo-yo dieting. We've already seen how this is associated with the development or worsening of diabetes. I'm always told to diet. It's dieting is the answer for all afflictions. And we're starting to see how prevalent that is in diabetes care as well. Diabetes is a risk factor for disordered eating and eating disorders. And yet, when are we assessing for that? Are we recognizing how, when we focus in on weight and weight numbers, how we're increasing the likelihood of disordered eating or re-triggering an eating disorder? Diabetes distress is clearly a problem in the diabetes community. We've known that. We've known that for almost 20 years. You know, are we asking about that? And then that self-blame, that internalized stigma, that thought that diabetes is my fault, and depression. So all of these things, the client is turning around saying, like, I don't get it. Why aren't you seeing this? I'm trying to talk to you. I'm trying to tell you these things. Why aren't you seeing this? And so that interaction between the, individual and the medical provider, this is the disconnect. And, for that, oops, oh, mercy my, I did not do the right thing. Pardon me while I have technical difficulties here. I'm gonna have to stop share for a second. Sorry. There we go. And I apologize for that little glitch here. All right. Thank you for bearing with me. So now what we want to do is we want to shift away from this numbers view, this quantitative. We're really trying to move to the qualitative. So shifting from numbers and outcomes to the client's direct experience is really a helpful first step in diabetes care. Really getting curious about the client's enjoyment. Are you enjoying eating your meal? Are you enjoying eating that X amount? Do you feel pleasure and satisfaction after eating food? These type of inquiries, kind of create a sense of being seen and heard, a sense of belonging. But pleasure is an important part of nutrition. Pleasure is an important part of life. And so many times when we're thinking about diabetes, we forgot that. And I feel like that's really one of the deep sadnesses that I have working in the diabetes space is many of my clients are not experiencing any kind of joy, no pleasure at all. And that's not okay. So when we talk about kind of going back to that, the quality, we're really looking at this idea of self-compassion. And for those who are unfamiliar with Kristen Neff's work, I really recommend, circling her name, Googling her, going to selfcompassion.org. And how she's had it set up is she has a really nice way of setting it up, saying that, kind of the unwanted behaviors are on the left and the wanted are on the right. So self-critical versus self-kindness. Self-critical is like, I caused this. It's my fault. Versus, self-kindness. I'm human, No one's perfect. No one's blood sugars are perfect. Isolation. Um, it's really turning around saying like, I did this. It's only me. You know, I, I can't be part of society. I don't belong because of my diabetes. And so that is really a big contrast from the common humanity, which is, of course, I belong. Everyone belongs. We're not trying to other people. And that common humanity, nobody's perfect. Everybody should have foods that they enjoy. That's a human desire. Over identification is thinking, well, is that dinner that we had out is what caused my A1C to go up. That's that focusing on these very small, narrow things instead of turning around and saying, like, well, there's other things going on. What else is going on? What else might be contributing? That curiosity. So that's really kind of how you can start imagining what self-compassion looks like and bringing self-compassion into the medical setting and really helping our clients see self-compassion, I think it's a beautiful thing, really helpful. So summary, weight, diabetes and weight stigma impact clinical engagement. Really, we see a great need for training medical staff. Um, Internalized weight and diabetes stigma impact clinical engagement, and clients who experience diabetes or weight stigma are likely to engage in maladaptive behaviors, which will worsen their overall health or diabetes. And just like before, we're going to open it up for those questions so I can kind of take them as they come. And guys are welcome to put things in the chat. And I know there was a question, a couple came up about slides. I don't know if the slides are going to be shared, but they are here. And again, all of the research is at the end.
We'll be sending slides out
Beautiful.
as we get them in from speakers. We want to put them in PDFs. And we do have a question in the Q&A. Is prediabetes really a thing?
Um, so there is a gap between having what we would consider normal blood sugars and having diabetes, and that space between them, that's what we call prediabetes. So that's a gap. And it is a diagnosis. So prediabetes is a diagnosis. Um, so again, kind of when we start thinking about, is it a thing? It is a diagnosis. There is a gap. There is a high correlation between prediabetes and development of diabetes. It really depends on a lot of other factors. So when people have prediabetes earlier versus later in life. Um, so that's kind of one of the things, if grandma gets prediabetes at 80, it's probably not going to be a big deal. But if we get it at maybe 25, it's really indicating that something's going on with the body. And it's not metabolizing, it's not being able to get the energy out of carbohydrates like other people. And as a response to that inability to get the energy out of carbohydrates, the body makes more and more insulin, and that's called hyperinsulinemia. And the hyperinsulinemia is thought to kind of burn out the pancreas, meaning that over time, this insulin resistance, this asking the pancreas to do more and more work, the body loses the ability to make insulin, and which ultimately leads to the diabetes. So that's that.
Okay.
Um,
And
yeah.
Megrette, we had some discussion in the chat about
Hmm.
CRGs and the fact that for some people
Hmm.
there's access issues, there are issues with them coming off, when
Oh,
they are
absolutely.
sweating and so forth. So I just kind of wanted to go back to that for a second and just
Mhm.
acknowledge that there are intersectional reasons why some people, may have more problems with them than others.
Absolutely. And again, we have devices that are coming up. I have people with skin allergies, or they might have like eczema or psoriasis, and they just don't work for them. And I get it. We're hoping soon, we do have implanted CGMSs, which, it's a device that goes underneath the skin, and therefore we don't have any adhesion issues, which is great. I think the piece I was really trying to get at is everyone should be offered this, and it should be financially affordable.
Mhm.
Okay. And when it's not offered, that's when I'm having a problem. And what I see in my practice is fat bodies are not being offered CGMS at the same rate thin bodies are. And that's wrong. And so that's the disparity. That's the social determinants of health. We're making assumptions that are they're they're creating inequity. And this idea that a fat body should lose weight versus being offered technology, to me, that is abhorrent. So we really want to look at that standard and turn around and say, is there bias happening? Yes, there's bias. We have research to say, yes, there's bias. So,
Yeah.
okay.
Um, we have one other question. Is
Sure,
there
sure.
specific ways to work on hyperinsulinemia that haven't been mentioned?
Um, Again, we're going to get a little bit deeper. We're going to talk a little bit more about the research around exercise, but movement, I think, is probably our best. Reducing the intake of saturated fats from animals is very helpful. Um, decreasing racism, decreasing stigma. These are just as effective as other things. And the question is, how do we do that? So kind of moving forward a little bit. And I do appreciate all the questions. And, I know that I'm not everyone's cup of tea, and we like who we like and we don't like who we like. I'm hoping this presentation is being offered in a way that's helping you guys really see there's a lot of research, there's a lot of great people doing a lot of great stuff, trying to help us understand intersectionality. Okay. So I'm going to keep going if that's okay. And so again, we really want to talk about focus is often, quantitative, and this can amplify feeling like a number. And it's really more important to really focus on the patient's direct experience versus the qualitative. Focusing on numbers erodes trust and decreases clinical engagement. Self-compassion can also increase clinical engagement, but access to medical care is an important part of diabetes prevention. And if I don't trust my medical care, I'm not going to access my medical care. If when I go to medical care, I'm getting judged, I'm not going to access that. So this is really important. Okay. Um, so let's talk about diabetes and weight stigma. So, the CDC defines diabetes stigma as negative attitudes, judgments, discriminations, or prejudice because of somebody because of their diabetes. And diabetes distress is the emotional distress that results from living with diabetes and the burden of a relentless daily self-management. And again, we know that diabetes distress, diabetes stigma leads to diabetes distress. So that relationship, it's pretty clear. Um, so I think it's really to understand that diabetes distress contributes to diabetes burnout, and burnout is when people grow tired of managing the condition and they ignore it for a period of time or worse, forever. So I want to talk about two myths surrounding stigma and diabetes care. So the first myth is there's just diabetes stigma. Um, and the second myth is that other types of stigma don't intersect with diabetes. And so again, there's only one type of diabetes stigma, and there's only diabetes stigma. And this can feel true because of the efforts of anti-stigma campaigns like Destigmatize Diabetes and enddiabetesstigma.org. However, diabetes is just one type of stigma, and there are 7 types of stigma. You know, we have diabetes stigma, we have financial stigma, we have gender, we have health and healthism, we have racial stigma, weight stigma, and then we also have the stigma of ignorance. Diabetes is a very heavy, knowledgeable, it's a lot of learning, and people really feel stigmatized when they're like, I've had diabetes for a long time. You don't think I know? And so that's the pushback. You don't think that I'm bright and able, you know, and that's how it's landing. Okay, so that's really um, really important. And one of the things we really want to understand is we don't solve stigma. So this isn't a problem that we solve. Stigma is a knot and we untangle it. And so that's really important to understand. We're not trying to solve stigma, we're trying to understand it. Okay. And I think a lot of times when we look at weight stigma, we can see that it really does overlap many types of stigma. And so we're really seeing how it overlaps there. But when we look at that, we can start seeing that weight and gender and race and diabetes, they're at the nexus of many stigmas. And so they're not all, pretty and equal this way. They really are very different for every person. And again, if we just pretend it's one, we're missing the larger picture. And you can see some of these are more forward or more back. Okay. So again, kind of the summary right here is that stigma is complex and intersectional. You know, weight stigma is part of diabetes care. We're really trying to untangle stigma, and that's our own work. Like we have to do our own work to untangle stigma, and we have to acknowledge that stigma is in our society. And stigma is something that's present and it requires effort to identify, reduce, and repair the damage caused by stigma. Um, so I am a little bit mindful of the time. Gosh, they gave me so much time, and I thought, oh, I'm going to have extra. Um, but I am going to, again, once again, people, if you want to, put in comments and kind of go from there. Is there anything else that questions from what we've gone about that intersectionality of stigma? So now we're going to be digging deeper into stigma. And it's really important to understand stigma is a complex matrix. And so there's enacted stigma, and this is when a person is experiencing stigma, and there's perceived stigma, and this is when the threat of stigma is present or anticipated. So, and understanding stigma is actually very complex. So when we think about the enacted stigma, kind of down the side, we have social stigma, discordant stigma, and self. And the social stigma, some people think that I'm inferior because of my illness. Discordant is when it doesn't match up. I've been blamed for poor outcomes. And it's that feeling of the stigma. And then the self stigma is I'm not a good person because I have. Perceived stigma, again, it has that same three down the side, the social, discordant, and self. I don't tell my friends about it. Discordant, I don't talk about my illness. Um, self, you know, I dare not make friends because of my illness. So when we look at that, we're understanding it's the Caden Institute Stigma Scale. It is a validated questionnaire that can be used around non-communicable diseases, and you can see how it's laid out like a matrix. So one of the things I really want to understand and have you guys all understand is stigma cannot happen in isolation. We need another person. And it is the interaction between people that causes stigma. So I myself cannot experience stigma if I'm alone. Okay. It is my interactions within other people that create stigma. And so that's that sense of belonging that we're really dealing with. And so tools used to evaluate diabetes stigma, these are a couple that are listed. I want to highlight them because if we're in public health or we're in a medical setting, we have scales that are validated that can help us start understanding this intersectionality, this knot that we're trying to untangle. And I think we can assume that stigma is always going to be present. The question is, what do I want to do about it? How do I want to measure it? What efforts can I take? And so we talked about the cadence, how it has the two parts, and it has those three subcategories. So, and again, I'm going to just open it up for questions to see what people have. Um, yeah.
Yeah, I thought this was a really great question. I wonder who you feel is responsible to untangle this. And the same person states, I'm finding my energy to fight this with my doctor has left me with little energy to do so. Who are our allies? And yeah, I was on a call last night with, over 100 fat folks talking about this exact kind of thing. And we fat folks get burnt out.
Yeah, for sure.
Yeah.
Yeah, for sure. And I think it's a great question. I unfortunately I don't have the answer. Um, I I don't even think people are asking the question. So I'm hoping that this presentation will be seen by healthcare professionals, by organizations, by public health departments. This is work we need to do. So it's not the work of fat bodies to go educate. It's our work, you know. And I know that that conversation has been in the chat, and I want to acknowledge it. Um, and again, it's this larger issue. It's so painful. Stigma is so exquisitely painful that we do need to recognize that healing and how we go about this is, it has to include individuals that have experienced stigma. It needs to go gently. But it's a knot and we got to untangle it. It's not simple. And I guess that's really, really what I want to say is that I don't have the answer. I think it needs to be come together. And I think we need to listen to, and give the platform to fat bodies. Again, when we're looking at this issue, we have the unspoken villain and that is we are having a lot of money go into diabetes care surrounding and paid for by weight loss uh, surgeons and surgery centers and medications. And this is actually minimizing and decreasing agency of people with diabetes because now weight loss is more important. It's the cure. And so again, we're not actually, I perceive that the people and the needs of people with diabetes are becoming lessened because of this emphasis on weight. But that's my perception. I don't have any grounding. But I think we have to be really careful. And I think, one of the speakers coming on, Reagan Christine, she does a really nice job of really pointing out, wow, pharma is changing the conversation and not in a good way. And and she walks it through, and I don't want to take away. I know she's talking, so I really, for those people who um, can go hear her talk, I I just really value her work quite a bit. So let's talk about felt experience and active belonging. So felt experience that drives disengagement, and again, we're going to see this feeling othered um, or anticipating feeling othered, feeling a lack of ease or anticipating a lack of ease, feeling unseen and unheard, you know. And again, we asked about that, like, how do we untangle this knot? We have to have people that are having these experiences be part of, have the table, have the voice. Because if we don't, they feel unseen, unheard. They feel judged. And it's really important to understand that stigma is felt in the body. And this experience of being othered, lack of ease, not feeling seen or heard, it may not be able to be verbalized. People may not be able to say, I understand what's going on in my body and it's X, Y, and Z. That's because feelings don't have words. They're felt in the body. They're a felt experience. And, if anyone is hearing this and is saying, oh, yeah, I'm feeling that. I'm feeling that in my body. That's a feeling. You don't have to create a story. It's a feeling. And that is really kind of connecting with those feelings is just so important for us when we start kind of looking at this larger issue. And the felt experience that foster re-engagement is that sense of belonging, or that we're anticipating that I'm going to belong, that sense of ease, or we're anticipating a lessening of the burden, that feeling of feeling seen and heard, or anticipating feeling seen and heard, that we're feeling non-judgment or we're anticipating, I'm going to go to this place, I'm not going to be judged. That's really that re-engagement and care that we want. So simple summary side, your client's felt experience can decrease or increase clinical engagement. And an active belonging is really powerful. And it just seems so simple, but it's not. It's it's the individual's experience. It's not my experience. If I feel like I belong, but you don't, that's your experience. We got to give space for that. So I want to show you guys it's called the Inclusive Diabetes Care Pyramid, and it kind of gives a way to visualize this. Um, and so when we look at the pyramid, just like we did with uh, self-compassion, on the left-hand side are kind of the feelings or the experiences that we're trying to decrease. On the right-hand side, the experiences or feelings we're trying to increase. And so let's walk through each side. So again, it's a tool that depicts the impact of stigma and how to interrupt it in clinical engagements. It does have the two sides, and the left sides are the knots of stigma that limit clinical engagement. And so that othering and stigma. And that can be in life or specifically in diabetes care and lack of ease. So when we don't have ease, when we feel like I'm going to go to the doctor and it's going to be hard, or I'm going to go to the grocery store and it's going to be hard, or, I'm going to interact with somebody and it's going to be hard, that lack of ease, that is a barrier. And that lack of ease it's just really, really important to see that ease is a basic human need. So I'm going to say that again. The sense of ease is a basic human need. And when people don't have ease, they don't have a basic human need. Not feeling seen and heard, feeling judgment, or unsustainable self-care behaviors. This is what it leads to. We can't engage in sustainable self-care behaviors if we feel othered, if we don't have ease, if we're not feeling seen and heard, and we're experiencing judgment. Now, on the right-hand side are how we can interrupt that. And this is ways we can untangle belonging. How can we foster a sense of belonging? What can we do to increase a sense of ease? Remember how I asked you about the social determinants of health, that little asterisk next to it? Um, I think social determinants of health is really getting to this basic human need of ease, feeling seen and heard. And I think that's really important as well. And that's not just from others, but also from ourselves. We have to see and hear ourselves. We have to see and hear our needs and be able to do that really in a non-judgmental way. And we really need to focus in on non-judgmental counseling. So when we see these together, we're really trying to understand, hey, problems on the left, solutions on the right. And I think that's really important. And I want to call out the work of John Powell at the Othering and Belonging Institute. And we're going to talk a little bit more about bridging, but this is how we bridge. And that's really what the Institute talks about. Um, so when we're experiencing stigma and other, we want to create bridges to belonging. When we're experiencing that lack of ease, we want to create the bridge to a sense of ease. And we're really, that bridge is really, yeah, really important. And so, kind of in the summary, the inclusive diabetes care pyramid has the two sides, the othering, and on the other side is the belonging. And each of these five sides, we can see them as pairs, and we're looking for the bridge between those. Okay. Uh, so we really want to look for that bridge. How can we bridge between them? Again, I'm going to open it up for some questions and see what people have to say.
Thank you. Feel free to put questions in the Q&A if you'd like. And I'm just checking out. I've been trying to keep up with the chat. I like this comment from Brandy. I'm not diabetic, but I see this talk being related to every health condition I've ever had. And I think that's really important, that yes, a weight inclusive way of approaching healthcare would be much appreciated by the entire fat community. I'm confident. Um, let's see, loving the pyramid. I think that's an an excellent graphic, and folks really liking the talk. Uh,
Yeah, beautiful.
yeah,
Well, we have more to go, so we'll keep going.
okay.
Beautiful. So beliefs that decrease engagement. So there are four assumptions that drive disengagement, and I'm just saying that this is my opinion. This is not definitive, but the four is that clinical engagement is required. Okay. So there's an expectation from healthcare that I tell you what to do, you're going to go do it. And that is an oppressive standard. So clinical engagement is required. Clinical engagement is within reach for all people with diabetes. Clinical engagement is an individual responsibility and not a public health issue. And clinical engagement is primarily achieved by following the standards of care. These are four assumptions I really want all of us to think about and challenge. So when we think about it, breaking it down, clinical engagement is required. This assumption removes autonomy, which is a barrier of belonging. Having diabetes feels like you're being forced to join a club you didn't identify with or you feel like you belong to. Individuals cannot be persuaded or forced to engage. Clinical engagement is supported by society, systems, and organizations. And these structures, resources, and systems have to be present for all people with or at risk for diabetes. It's within reach. Clinical engagement is within reach. Consider how the social determinants of health impact clinical engagement. And though not studied and not cited directly in this talk, the American Diabetes Association has determined 60% of all outcomes of diabetes are related to social determinants of health. So 60% of all adverse health outcomes of diabetes are related to social determinants of health. Ready? It's not weight. Consider the impact of stigma, including on diabetes, financial, gender, race, weight. And what are the mental health concerns? How do those limit clinical engagement? If I'm under chronic stress or I've had trauma, how is that impacting clinical engagement? Again, that individual responsibility, not a public health policy. Increasing clinical engagement includes understanding the client's felt experience. Clinical engagement is more likely to occur when a client feels a sense of belonging, when they feel that sense of ease, when they have the feeling of being seen and heard without judgment. Societal, organizational, and institution systems can be both positively and negatively influencing clinical engagement. So we have to look at that. I think the last one is really talking about it's primarily achieved by following the standards of care. We just have to acknowledge that the standards of care alone will not overcome barriers to clinical engagement that are upheld by society, organizations, and institutions. So we have to honestly look at oppression and inequality in healthcare, and we have to look at oppression and inequality in diabetes space. So, kind of again in that summary, prevention efforts can focus on a weight or by reducing social determinants of health. I think you've seen that I believe current prevention efforts that are focused on weight are misguided. I don't see any evidence supporting chasing weight. I do see a lot of evidence supporting looking at social determinants of health. And there are beliefs and assumptions regarding clinical engagement that can perpetuate stigma. Again, we're at that place where just really opening it up to you guys so you can kind of chat or. And I know a lot of people are, um, really starting to kind of think about how this is so layered. And it is a very layered talk. And I really appreciate everyone hanging in. I know it's long. All right. Okay. So resources for inclusion, let's kind of get into that. So talking about stigma, I think is really important. So Destigmatize has created a language guide to assist healthcare professionals. And for those of you with a camera, you can just point your camera at this and it will bring you directly to that URL, which is listed underneath. And so some of those are, these include avoiding negative language, dehumanizing, depowering, desensitizing, and choosing language that's patient-centered, emphasizing that there is more to someone than their diabetes. So again, diabetic, person with diabetes, normal person without diabetes, um, obese is shifting to higher weight, uh, patient to client, difficult or challenging, finding it difficult, has concerns about, has other priorities right now, stricken or victim, lives with diabetes, denial, unmotivated, has concerns, diabetes complications has changed to diabetes related complications, disease has changed to condition, adherence is use the behavior. So again, it's a very long document. There's a lot of really good information here. But I think right now we're really recognizing this is an institutional issue. And I think language has been brought up a couple times in the chat. And I really want to indicate, if anyone in this talk is a researcher, look at the language guidelines. I know that people like the word obesity in clinical settings because it's a defined thing, but it is dehumanizing. And so, this is one of those things where we start talking about, are our patient handouts, are they making assumptions that weighing X is better than weighing Y? And so we really have to kind of look at that. And again, no one's perfect. Language is always changing, but I think that the effort is really essential. And again, it's okay for us to tell people, you know, could you step up your game? So we've come to the conclusion. I'm going to go through these slides again. This is, again, really an opportunity for people to ask questions. We're going to open it up for the Q&A. I'll turn off my screen and we can talk and look at my face. Um, but really, when we look at a weight-inclusive approach, it acknowledges that weight loss is not helpful for every person with diabetes, that there are risks associated with dieting. Dieting can increase the risk of developing type 2 diabetes, and it can worsen heart disease. And engaging in non-weight focused behaviors uh, uh, changes can support blood glucose management. Client focus is often, quantitative, and this can amplify feeling like a number. Um, and sometimes it's given preference to greater than the client's direct experience, which is, qualitative. Focusing only on numbers erodes trust and it decreases clinical engagement. And self-compassion can also increase clinical engagement. And again, the work of Kristen Neff is uh, important. Assessing medical care is an important part of diabetes care and prevention. Weight-inclusive diabetes care identifies that stigma decreases clinical engagement. Weight stigma is part of diabetes care. Stigma is complex and intersectional. Healthcare organizations and professionals can help untangle stigma in healthcare and acknowledge stigma in society. Stigma is something that's present and requires effort to identify, reduce, and repair the damage caused by stigma. We understand that stigma has two parts, enacted and perceived, and within both of those, there's social stigma, discordant stigma, and self-stigma. The client's felt experience can increase or decrease clinical engagement. And that we're really looking at how to bridge between the sense of othering and belonging, the sense of unease or fatigue with ease, the sense of being seen, unseen, and unheard versus being seen and heard. And judgment versus non-judgment, and sustainable self-care, unsustainable self-care with sustainable. So we're trying to find those bridges. How do we bridge between those two? And, diabetes prevention efforts can focus on a weight or addressing social determinants of health. And I think that it's really important to recognize where's the evidence pointing. We're really not seeing any evidence supporting weight. We are seeing evidence, a lot of evidence, really looking at social determinants of health. And, there's beliefs and assumptions regarding clinical engagement that does perpetuate stigma. Become aware of the many ways to destigmatize language surrounding diabetes, gender, disability, weight, and medical care. Becoming more aware of weight stigma, challenging the beliefs that dieting is without harm, and explore the resources that can empower our clients, such as destigmatize.org, enddiabetesstigma.org, or behavioraldiabetesinstitute.org. So that's that. And I think there was a really good comment that was brought up in the chat about using the O word. And so I will take that at heart, and I apologize for any harm that I did do. I recognize that I did not screen this talk to use the O word in place, and I apologize. I acknowledge that and appreciate everyone's um, hearing me say that. So thank you. So we're at the question time, and and I just want to share because I know this was asked. So at the end of the slide, these are all the different research articles that were provided as well. I think that's all of them. So they are all there, and I guess the slides are going to go out. And so we're at questions, and I'm going to stop sharing my screen, and then you can see me. I think yes. So there we go.
Great. Thank you so much, Megrette. We do have a question. Where do the studies that show small amounts of weight loss can improve diabetes symptoms, A1C, fit into this conversation? Would you recommend slow, progressive weight loss or disregard and focus on social determinants of health?
Okay. Very complex question. So thank you forever who came up with it. So my research, which is hopefully coming out very soon, we in a group of us, there was about 6 of us, looked at over 7,400 and something studies. I personally have read over 3,000 studies to look and see what are the moderators and mediators that cause changes in diabetes prevention projects. And so really what we did was we looked at that. So, 7,400 and some odd studies. And, it came down to 108 of those actually looked at the moderators and mediators. And of those 108, it really came down to 3 research studies that really looked at this. And when we asked, did it improve outcomes? We didn't see it did. We actually saw that it caused harm. So when you hear about weight loss studies that say small amount of weight loss improves outcomes, I just want you to question that. And again, I think Reagan does a great job of breaking it down. She's very inspiring how she looks at weight loss, at all these research that's coming out. She's very inquisitive, and I encourage us to be very inquisitive. The research that I've done, the reading that I've done, my understanding, I do not see any evidence that says it's weight. I do see evidence that we need to move our bodies, we need to nourish our bodies. We need to care for our body. This being that we have, it's fragile and it needs care. And, I as a white body can identify how my white body needs care. I can't identify how someone else's body needs care. So we need to give some space to that. And so again, when we talk about behaviors, ask yourself, is it a behavior or an outcome? Weight loss is an outcome. It's not a behavior. I can't do weight loss in my seat. When we say, well, we have to have less stigma, that's an outcome. What do you do to get less stigma? So really focus in on the behaviors. And I think that when we see that, we're going to really see improvements. And so again, when we focus in on behaviors around diabetes, we see improvements. And those behaviors are, can I find a provider that can support me? So that's kind of where I am. And again, it's hard because I, read the studies and, this research that we're coming up is really, hopefully it will be published in 2025. But it's heartbreaking for me just to see how I feel like we've run down the wrong rabbit hole and we're not going to get out. We have to back up and really look at behaviors. Yeah. Yeah.
Yeah. Okay. Yes, the Center for Body Trust folks are presenting tomorrow. And they'll, between them and Reagan and some of the other folks, will definitely be building on this conversation. So if there aren't any more questions, I'm going to let Megrette continue her day, and we will be back in a couple of minutes, I believe 12:45, to begin our next session. So thank you, Megrette, and thank you to all of you for being here, and we will see you shortly.
Take care, everyone. Thanks so much for your time.